Welcome to our live webcast, What's New and Exciting in ATTR Cardiac Amyloidosis in 2024. Thank you for joining us. My name is TJ, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There's a large window which holds all your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. We are joined today by our speakers, Dr. Frederick Ruberg and Dr. Omar Siddiqui. Dr. Frederick L. Ruberg is the Thomas J. Bryan Professor of Cardiovascular Medicine and Professor of Radiology at Boston University, Chobanian-Avedisian School of Medicine, and Chief Section of Cardiovascular Medicine at Boston Medical Center. Dr. Omar K. Siddiqui is an Assistant Professor of Cardiovascular Medicine and the Program Director of the Cardiovascular Medicine Fellowship at Boston Medical Center and the Boston University School of Medicine. He is also an attending cardiologist at the Boston University Amyloidosis Center. And now I will turn it over to Dr. Ruberg to begin our presentation.
Thank you very much. This is Frederick Ruberg from the Boston University Amyloidosis Center and from the Section of Cardiovascular Medicine at Boston University Chobanian-Avedisian School of Medicine and Boston Medical Center. It's my pleasure to join you today with my colleague, Dr. Omar Siddiqui, also a member of the Section of Cardiovascular Medicine and the Amyloidosis Center. We're delighted to present to you today updates in ATTR cardiac amyloidosis, what's new and exciting for 2024. We are very grateful for our sponsors, the Amyloidosis Foundation and Prothena, and we look forward to answering your questions in the Q&A section of this presentation at the conclusion of our presentation. This will be a two-part presentation, the first part presented by Dr. Siddiqui and the second part presented by me. Thank you again for your attention, and we are delighted you could join us today. And now I'd like to present Dr. Siddiqui with part one of today's presentation.
Thank you, Dr. Ruberg. It is my pleasure to present the first part of this webinar. This is my outline. I'm going to talk about what amyloidosis is in brief. I'm going to talk a little bit about transthyretin amyloidosis and what does it do to the heart. We're then going to discuss our overall treatment strategies for ATTR amyloidosis in 2024. And then finally, I'm going to take you through emerging treatments and clinical trials. This is a very exciting time for our field, and there are, as you will see, a lot of new and cutting-edge treatments in development. So to start our story off, what is amyloid and amyloidosis? Amyloidosis is a disease of protein misfolding. Our bodies are factories of protein manufacturing. We make all kinds of proteins that are important in necessary function for our biology. The term amyloid refers to protein fragments that misfold, and they, as a result of that misfolding, have a characteristic staining pattern with a dye called Congo red when looked under a special light. The term amyloidosis refers to a disease that comes from these misfolded proteins when they deposit in various organs. When these proteins deposit in organs, they result in organ dysfunction. They cause the organs not to work properly. So far, we have identified about 35 different proteins that are precursors for these amyloid fibrils. On the right panel, you see a cartoon of the transthyretin protein, which we're going to talk more about, and how it circulates as a tetramer, as a four-unit molecule or four-molecule unit. It dissociates into smaller units, which then misfold and result in these sticky fibrils that deposit in various organs. Amyloid protein or amyloid fibrils deposit in between the cells of the heart. The cells of the heart are known as myocytes. The amyloid fibrils will deposit in between the myocytes, leading to thickening and stiffening of the heart muscle. You can think of cardiac amyloidosis as a disease of relaxation. The heart has to relax to fill with blood, and then it squeezes the blood out to the rest of your organs. In amyloidosis, when it affects the heart becomes stiff and has difficulty in relaxing. Therefore, it fills at very high pressures, and these pressures then back up into the lungs and into other parts of the body, like the abdomen and the legs. This also prevents the heart from augmenting the cardiac output or the amount of blood that it's pumping out when a patient with amyloidosis exercises. And that's what results in shortness of breath and the symptoms of exercise intolerance. In addition, the deposition of these protein fibrils in between the heart myocytes may actually also result in direct injury to the cells, thus leading to further heart dysfunction. We're going to focus on transthyretin protein because this is the precursor protein that leads to the most common manifestation of amyloidosis, certainly the most common manifestation of cardiac or heart amyloidosis. The transthyretin name actually describes what this protein does. It is a transport protein for thyroid hormone and retinol, which is another name for vitamin A. The thyroid hormone transport function of TTR is fairly minor because you actually have another protein transporter for thyroid. But this is a major transporter for vitamin A. And this is what it looks like under crystallography. This is actually a cartoon, but it shows you the 4 subunits that make up a proper, the whole tetramer of transthyretin. This cartoon illustrates how our bodies make transthyretin protein. It's made in the liver. Another name for this is prealbumin. So if you're looking at your labs, you will see prealbumin levels, which is just another name for transthyretin. The liver has genetic code for making transthyretin protein. The genetic code results in something called messenger RNA, which is then translated into the actual protein that circulates in the body. Over the course of its metabolism, it will break down into smaller subunits, which may then misfold and become these sticky fibrils that deposit either in the heart, causing what is known as a restrictive cardiomyopathy. And what that simply means is that this is a disease characterized by difficulty in relaxing of the heart. It may also, the transthyretin amyloid fibrils may also deposit in the nervous system, resulting in a peripheral neuropathy or an autonomic neuropathy, where people may have difficulty maintaining their blood pressures when they stand up. The question that then comes up is, why does transthyretin misfold? We talked about the essential functions of the transthyretin tetramer and how it results in amyloid fibril formation, but we have an incomplete understanding of how that happens. We know that some people have an error in the genetic code of the transthyretin gene. This is something that's heritable, meaning that it is passed down in families. This kind of transthyretin is known as hereditary ATTR or variant ATTR. However, the vast majority of patients with transthyretin cardiac amyloidosis have a genetically normal protein, and that's called wild-type transthyretin protein. These people will develop transthyretin amyloidosis as they get older, and we sort of have an incomplete understanding of why that happens. We know that ATTR wild-type amyloidosis is associated with aging, particularly in people in their 7th and 8th decade of life. We know that it's associated with male sex, but we have sort of an incomplete understanding of why this process happens exactly. I'm now going to talk about our treatment strategies for ATTR amyloidosis, and I'm going to use this schematic of how the protein is made, how it misfolds, and how it deposits. So we covered this idea that transthyretin is expressed in the liver. The genetic code allows the liver to produce transthyretin, which then circulates as a tetramer that dissociates and deposits in the heart and in the nervous system. So we can actually intervene at every point in this cascade of amyloidogenesis, or the production of amyloid protein. We can inhibit transthyretin synthesis. Back in the day, people used to do that by liver transplantation, because the idea was that if you could give somebody a liver that produces normal protein, maybe these patients would not have a transthyretin amyloidosis. This was done in patients who had the hereditary form of the disease. However, liver transplantation, as you might imagine, can be a very morbid procedure. It is associated with a lot of complications, the need for long-term immune suppression, and it turned out that these patients would still get amyloidosis down the road. Nowadays, what we do is we have a whole armamentarium of gene silencing options, where these are drugs that act at the liver, at the level of the liver, preventing the liver from producing transthyretin protein. So they shut down the amyloid factory that's responsible for amyloidosis. And there are two classes of drugs, something called small interfering RNA, siRNA, or antisense oligonucleotides. Professor Ruberg is going to go through some of these drugs. I'm going to go through some of the other ones. More recently, we have the ability to actually edit the genome by using molecular scissors known as CRISPR-Cas9 that allow us to essentially snip out the part of the gene that codes for the transthyretin protein. And that's going to be the subject of another interesting trial that is going to be starting soon that I will cover. Once the transthyretin molecule is circulating, there are other drugs that bind to the stable tetramer, preventing it from breaking down, in the hopes that that will prevent the formation of these fibrils. These are called TTR stabilizers. There is a non-selective agent, which is a non-steroidal anti-inflammatory drug called diflunisal, which we use off-label for this particular purpose. However, more recently, we have the only FDA-approved treatment for this, which is tafamidis, which is a TTR stabilizer. And then we have a newer drug that is in clinical trials, and the clinical trial has just reported, and that's acoramidis. When the TTR transthyretin fibrils deposit in the heart, they result in heart dysfunction that we've already covered. We can intervene at this level as well by allowing the body to degrade these transthyretin fibrils. There were older drugs like doxycycline and ursodeoxycholic acid, which have not shown to be very effective. And more recently, we have two monoclonal antibodies, PRX004 by Prothena and NI006 that I will also cover, that are in clinical trials right now. The hope is that these antibodies will allow the body's immune system to target and clean up the transthyretin fibrils that are in the heart and in the nervous system and other parts of the body. This table provides you with an overview of emerging therapies for transthyretin cardiomyopathy, or ATTR cardiomyopathy. Dr. Ruberg will go through some of the other drugs that are in use right now. There are 5 trials that have concluded or are actively recruiting, and I'm going to go through them in detail. Before we do that, I am going to explain the concept of TTR silencing, or gene silencing. I had briefly mentioned it as a process by which we shut off the amyloid factory that's producing these amyloid proteins, or these fibrils. These are drugs that are usually injectable, so that are either given by intravenous injection or subcutaneous injection, and they act at the level of the messenger RNA, preventing the translation of that RNA into protein production. And they can turn off TTR production by up to 90%. And so the idea is that if no transthyretin is produced by your liver, then that will seriously attenuate the production of these fibrils and the deposition of these fibrils. The drugs do wear off over time, and TTR levels return to normal if you're no longer taking the drug. These gene silencing drugs are approved by the FDA currently for hereditary, so the variant transthyretin polyneuropathy. These are patients with the hereditary disease who have the peripheral neuropathy or the autonomic neuropathy. And they can have cardiomyopathy, they can have heart disease, but these drugs are not FDA approved currently for people with heart disease. The first trial, so I'm going to go through some of the trials that are currently ongoing or have just completed recruitment. The first one I'm going to talk about is known as Helios-B, which is a study to evaluate the drug vutrisiran in patients with transthyretin amyloidosis with cardiomyopathy. Vutrisiran is a small interfering RNA, siRNA. It is currently FDA approved for patients with the transthyretin polyneuropathy. It is not yet approved for patients with cardiomyopathy, and that is the focus of this trial. This is a randomized controlled trial, so patients are randomized to either receive vutrisiran or placebo, which enrolls 655 participants. Patients or the participants got vutrisiran once every 3 months or placebo in a 1-to-1 randomization. 30% of these subjects were also on tafamidis, which is the, like I said, the FDA-approved TTR stabilizer. The primary endpoint of this trial is a composite of all-cause mortality and cardiovascular events and urgent heart failure visits. This is going to be the first trial to report out this year, and the plans are for this trial to be reported sometime in June or July. You may have heard recently that the sponsor, the company that makes this drug, Alnylam, recently changed some of the endpoints. They increased the amount of time that they're following some patients. They will also compare the vutrisiran, the patients who got vutrisiran, with patients who were on no drug, as well as comparing vutrisiran with patients who only got tafamidis. The next trial I'm going to talk about is known as Cardio Transform or Cardio TTR Transform. It's a study to evaluate safety and efficacy of the drug epiontersen in patients with transthyretin-mediated amyloid cardiomyopathy. Epiontersen is what is known as an antisense oligonucleotide. So this is again a TTR gene silencer. This acts at the level of the messenger RNA, at the level of the gene sort of translation machinery, and it prevents the body from producing transthyretin protein. It is FDA approved, similar to vutrisiran. This is also FDA approved for transthyretin peripheral neuropathy. These are patients who have the hereditary transthyretin peripheral neuropathy or autonomic neuropathy. This trial is a randomized controlled trial enrolling 1,438 participants. Subjects get epiontersen every 4 weeks versus placebo, and the primary outcome is composite of cardiovascular mortality and recurrent events. This trial has completed recruitment or enrollment, and the plan is for them to report out the results sometime next year in 2025. Now I'm going to talk about some of the trials that are currently ongoing. The first one I'm going to talk about is an anti-transthyretin fibril antibody. This is a drug that is now called NNC6019. It was formerly called PRX004. And I'm also going to talk about another antibody known as NI006. These are humanized monoclonal antibodies that bind to unique areas in the misfolded transthyretin protein. What's cool about these antibodies is that they will bind to areas of the transthyretin protein that are exposed only when the transthyretin misfolds as an amyloid fibril. So they do not bind to normally folded transthyretin. When they bind to these misfolded fibrils, these antibodies activate the immune system, and they allow your immune system to bind to them and use the immune system to clear the amyloid fibrils. This is a very powerful therapy because the idea is that your heart and nervous system are not functioning properly as a result of these fibrils that are deposited there. And so the idea is to try to clear your organs of these fibrils in the hopes of restoring organ function. The PRX004 antibody, also known as NNC6019, was studied in a phase 1 study that showed there was no adverse events, so they proved safety of this antibody. 3 out of 7 patients had improvement in their peripheral neuropathy, and all patients who had heart involvement maintained stability during the trial. They did not get worse. The phase 2 trial is now enrolling. The next antibody that I will discuss is known as NI006. This was the subject of a phase 1 trial that was published in the New England Journal of Medicine in 2023. This phase 1 trial recruited 40 patients who had transthyretin cardiomyopathy and heart failure, and they randomized them in a 2-to-1 ratio to get this antiviral antibody, NI006, or placebo by IV every 4 weeks for 4 months. This phase 1 trial showed that there was no drug-related adverse events, so again, they established safety. This trial also had imaging findings, cardiac MRI and pyrophosphate scan, that supported an improvement in cardiac amyloid burden in those patients who got the antibody. And the cardiac biomarkers like high sensitivity troponin and NT-proBNP, which are markers of amyloid cardiomyopathy, which are markers of disease, were reduced in the patients who got the antibody. This NI006 is now known as ALXN2220, made by Alexion. So based on that phase 1 trial, the success of that phase 1 study, there are now plans for a phase 3 trial, which is known as deplete TTR cardiomyopathy. It's a study of ALXN2220 versus placebo in adults with transthyretin cardiomyopathy. This trial is just opening and it's starting to recruit. The plan is to enroll 1,000 participants, so this will be a large trial. There's a weight-based dosing of the antibody versus placebo every 4 weeks for at least 24 months, so up to 2 years, for at least 2 years, up to 4 years. The primary outcome is the composite of all-cause mortality and total cardiovascular events up to month 48. So this trial you might hear about because this is starting to enroll now. And then the final trial and the final drug that I will discuss in my section is this idea of gene editing. And this mechanism is known as CRISPR-Cas9. This is the drug complex. And this is really thought of as the ultimate gene silencer because this acts at the level of the gene and it edits out the genetic sequence that encodes for the transthyretin protein. The drug is known as NTLA-2001, and it basically has several components that you can see on the cartoon on the right. It has a TTR-specific guide RNA that allows the drug to target the transthyretin gene. The drug is encased in this lipid nanoparticle that's picked up by the liver, and then the guide RNA allows it to target the gene. There is also a gene that encodes for the actual molecular scissors, which is this caspase-9. And so the idea is that the drug binds to the transthyretin genetic code, and then it snips out the part of that gene that encodes for the protein. In the phase 1 trial, there was permanent silencing of transthyretin production. 6 patients had a reduction of almost 90% at 28 days at the highest dose, and this is published in the New England Journal of Medicine in 2021. Based on this trial, there is now a new trial called Magnitude, which is currently enrolling. This is a phase 3 study of NTLA-2001, so that CRISPR-Cas9 complex, in patients with transthyretin cardiomyopathy. This is going to be a randomized controlled trial. The plan is to enroll 765 participants. It's a single IV infusion of this CRISPR-Cas9 drug versus placebo. This trial is interesting in that, first of all, this is just a single IV infusion that edits out the gene for transthyretin, and the duration of the study depends on the number of events, which is estimated to take up to 48 months. But the study will keep on going until there's a certain number of events, cardiovascular events that take place. The primary outcome is a composite of cardiovascular death, cardiovascular mortality, and cardiovascular events such as heart failure, hospitalizations, and other heart failure manifestations. So to summarize my part of this webinar, Transthyretin cardiomyopathy is a disease that's caused by deposition in the heart of misfolded transthyretin fibrils that then result in heart dysfunction. Transthyretin cardiomyopathy causes thickening and stiffening of the heart muscle. So you could think of this as a problem of the heart relaxing. As the disease progresses, there will also be problems with the pump function, but early on in the disease is characterized by thickening and stiffening of the heart muscle. Emerging therapies are focused on silencing production of the transthyretin protein by the liver. These are gene silencing therapies or CRISPR-Cas9 gene editing, or clearing of the amyloid fibrils that are deposited in the heart by one of the two antibodies that I mentioned. Thank you very much for listening, and with that, it is my pleasure to turn over this presentation to Dr. Ruberg.
Thank you very much, Dr. Siddiqui. And now it's my pleasure to present part 2 of this webinar. So during part 2, we'll talk about what's new in the genetics of hereditary ATTR. We'll talk about what's new in strategies for diagnosis, building on what Dr. Siddiqui already told you. And then we'll talk about what's new in reported new treatments, again, building on what Dr. Siddiqui has already told you. I think you'll find our two presentations to be complementary with a little degree of overlap, which I think will be helpful. So this is one of the overlap slides, just reminding everybody about the clinical manifestations of ATTR amyloidosis. This cartoon illustrates what Dr. Siddiqui already told you, that TTR, as you can see, is mostly made here by the liver, and then it basically circulates as a tetramer, which is a description of the protein. That tetramer can then break apart and then collect as amyloid fibrils, which are illustrated in this cartoon here, that collect in the heart and cause thickening of the heart muscle, heart arrhythmias, and something called cardiomyopathy, which leads to congestive heart failure. Now, we remember that amyloidosis from ATTR is a multi-system disease. It's got manifestations in the cardiovascular system, and these are medical descriptions of that. And principally, it has manifestations in the nervous system. And we think we've previously conceived of these diseases as two separate entities, but there is a growing consensus that this is a continuum, obviously, because it is one amyloid protein fibril that causes abnormality in the heart and the nervous system. And future trial designs are beginning to think about these diseases together as opposed to neuropathy or just cardiomyopathy. There's also gastrointestinal manifestations, musculoskeletal manifestations, including spinal stenosis and carpal tunnel, that I'll talk about in more detail, as well as kidney disease that can occur as a result of the problems with circulation. So you've seen this slide already. Again, it illustrates the TTR that's made by the liver and that it misfolds and then aggregates into these things called amyloid fibrils. And Dr. Siddiqui already introduced to you that there's a hereditary form called ATTR-V, which stands for variant, or H-ATTR for hereditary, and a non-hereditary form that's called ATTR wild type, previously called senile systemic or senile cardiac amyloidosis, because it affects people typically of older age. We're going to dig down a little bit more on this hereditary form of amyloidosis. So let's remind ourselves about basic biology. So, and I think this is really useful to understand as you think about the therapies that we use to treat TTR amyloidosis. So remember, the problem is in TTR, you have a protein that misfolds. Sometimes that occurs because there is an error in the DNA. This is the DNA here. The DNA is what's in all of our cells in the nucleus, and DNA is, as you all know, the building block of biology. And your DNA is acquired from your parents. You get some of your DNA from your mother and some of your DNA from your father. And DNA is divided into things called chromosomes. And again, you get half of your chromosomes from your mother and half of your chromosomes from your father. That DNA then is transcribed, that's the term, into something called messenger RNA. And then that messenger RNA is then translated, that's the term, into something called protein using a structure in our cells called ribosomes. And proteins are known as polypeptides. Now, this is the problem with amyloidosis. This protein here, called TTR, misfolds. But in some people, the reason why the protein misfolds is because they've inherited an abnormality in the TTR gene up here at the DNA level that leads to an abnormality in the protein. So our therapies to treat amyloidosis are directed at the protein itself, and these are called stabilizers. I'll show you in another slide. They're directed at making the cell make less mRNA, and these are the silencing medications. And as Dr. Siddiqui introduced, there's even a new therapy that works at the DNA level to basically cut the DNA of the TTR protein and make the patient not make any TTR. So this is really kind of ingenious, and the ways in which we kind of can approach these. Remember, TTR is produced in the liver primarily, that circulates in the body. So these therapeutics are all basically directed against liver DNA, liver RNA, and then circulating protein. And this is basically an illustration of a polypeptide chain or a protein with the constituent amino acids that make up that protein. And in the case of hereditary or variant amyloidosis, a single base pair switch in the DNA leads to a substitution in the amino acid of the protein for a different amino acid, in this case isoleucine in place of valine for this particular variant, V122I or V142I. It's the same thing, and that leads that protein to become unstable and misfold. So as you all know, there are, and as Dr. Siddiqui introduced, there are over 100, maybe even 130 different variants in TTR that exist. V122I or V142I or Val122ILE, all the same name, all the same variant, is the most common. But other common variants in the United States, for example, include the T60A or T80A variant, or the V50M or V30M variant. Those are the three most common variants in the United States. Worldwide, depending upon where in the world your family comes from, there are different variants. For example, in Italy or in Sweden or in Japan, for example, just to name a few countries in the world where different variants exist, or Northern Ireland in the case of the T60A variant. Now, I mentioned that you get half of your DNA from your mother and half of your DNA from your father, and that leads to the way in which ATTR amyloidosis expresses itself in families. And we call this particular inheritance pattern autosomal dominant. And that means that if you inherit a recessive gene, in this case, a dominant gene, in this case, say T60A, there's a 50% chance, you can see here, that a child is going to inherit that same gene, just because you have two parents, and that's what probability says. We recombine these chromosomes. Because the gene is autosomal dominant, that means one copy of the gene is enough to cause the disease, ATTR amyloidosis. Now, the confusing thing is that this just the presence of the gene doesn't mean that a patient is going to necessarily have ATTR amyloidosis. We call that concordance between the inheritance of a gene and the development of the disease genetic penetrance or phenotypic penetrance. And in amyloidosis, there is variation in the degree of penetrance by the type of gene. That creates some confusion, and I'll talk about that in a future slide. But generally speaking, if a patient has T60A or V122I or V30M, then a child, their children, has a 50% chance of acquiring that gene, and therefore is at risk for developing ATTR amyloidosis. Now, the interesting thing, there are many interesting things about ATTR amyloidosis, which is why I study it. But one of the things I find most fascinating is that these genes are present since birth. So a patient who is given a gene to their child, that child has ATTR gene variant. They've got V50M or V122I since they're born. And so there's this, but the disease only manifests itself later in life. There are no cases that I'm aware of childhood ATTR amyloidosis. But as people get into their 20s, 30s, 40s, and certainly as they get older, the disease penetrance becomes higher, and people are more likely to manifest disease. So there's this long preclinical period, you can see here in this slide, where people have the variant, and their TTR is theoretically misfolding, but it's not causing amyloidosis. So there's got to be some other processes that are contributing to the development of amyloidosis in the context of a gene variant. That's illustrated here as well, where in this particular slide, a patient has a variant. They've got no ATTR cardiac amyloidosis, but then over time, the gene begins to cause misfolded protein that collects in the heart, and you get subclinical ATTR-CA, where basically if you did some sensitive tests, you could find it, but there's no clinical manifestation of it, and then it becomes symptomatic, and that leads to basically kind of a relatively precipitous decline, depending upon the variant over time. And so the challenge is to basically, one, understand why this is happening, and that's the subject of many people's research, including my own, but also to understand what are the factors that we can look at that might identify early disease. So I've become very, very interested in this particular variant, V142I or V122I, which exists in about 3.4% of people who identify as black in the United States. It's originated in West Africa. It's the most common variant worldwide. We now understand that this variant is very important to black individuals in the United States because of its prevalence as a means for causing heart disease. This is a paper that was published last year in the journal JAMA Cardiology, where they looked at, using population studies, what age do variant carriers begin to show excess risk of certain heart problems versus people who are similar to them in terms of their race identification, their age, and their sex for having heart problems. And what they found here was that people who have acquired the V122I variant, V142I variant, their risk for atrial fibrillation begins at age 65 compared to those who don't have it. Their risk for heart failure begins at age 70. Their risk for increased risk of death begins at 75. And when they get over the age of 80, there's about almost a 25% increased risk of mortality from heart failure. So this suggests that there are over 1.5 million people who carry this allele, and we are not doing a particularly good job of identifying people and getting them to appropriate amyloidosis screening to determine whether or not they have cardiac involvement. Because, as you all know from Dr. Siddiqui's presentation, this is now a modifiable disease. We have treatments for amyloidosis, many potential treatments. And so identifying people who are at risk and treating them before they have developed disease or at the early stages of disease is critical. And that's the subject of work that I've done in my group. So I lead a study with Dr. Matt Maurer at Columbia University called SCAN-MP, which is designed to understand the burden of disease that ATTR amyloidosis confers to people who identify as black with heart failure in the United States. And this is an initial analysis from about 275 or so patients. We've now recruited about 650, actually, and so there'll be subsequent analyses coming out, I hope, in the next year or so from this study. But this initial analysis we thought was very important, and we wanted to get it out into the scientific world. We found that in this population, we found about 7% of patients had cardiac amyloidosis that was undiagnosed, so newly diagnosed patients who were recruited from Boston University, Yale University, or Columbia University. But what we found was about 60% of them actually had wild-type amyloidosis. So that was a bit of a surprise. We thought if people were older and they were black and they had heart failure, they would most likely have the variant because of that high prevalence of variant that I told you, 3.4%. But no, actually more than half of them had wild-type disease. And that's important because that means you just can't look at someone's genotype and say whether or not they're likely or unlikely to have amyloidosis. Because if they don't have a variant, they still could have wild-type disease. We also found, importantly, that the penetrance of the variant was low. Well, I'd say intermediate, 40%. So that means that there are people out there who had heart failure who look like they could have amyloidosis. And when you look at those who actually have the variant, only 40% of them at this age, this is a mean age of about 65 to 70, actually had penetrant disease. They had heart failure for another reason. This underscores how challenging it can be to understand whether or not the amyloidosis is causing this patient's disease that's in front of them. But this means that again, just because you've inherited allele as a patient and you happen to be 65 years old with heart failure, it doesn't mean that you've got amyloidosis as the cause of your heart failure. And this underscores why it's important to be seen by an amyloid sophisticated center, or at least by a clinician who understands what the testing algorithm is. And so we're in a world now where we're pretty good about identifying people who are here, who already have symptoms of disease, and using sensitive imaging techniques of the heart, like magnetic resonance imaging or special scintigraphy. And I'm going to show you in a second about positron emission tomography. We can push the diagnosis even further on. We're really getting to a point now where in the future we're going to be looking at orthopedic manifestations potentially as a means to identify who has disease and who doesn't. And orthopedic manifestations are the focus of a number of different research groups. This is data from Dr. Maurer's group again, and I will tell you that this has been followed up by a multi-center collaboration study that my group participates in, funded by the National Institutes of Health. And this study basically looked at patients who had spinal ligament surgery from spinal stenosis. Small study of about 50 patients, and they found about 30% of them actually had amyloid in their spinal ligaments. And when they looked at those patients, they found that one of them had undiagnosed cardiac amyloidosis. So again, small numbers of patients. But this suggests that one way in which we can identify patients is by looking at the spinal ligaments of amyloid of patients who are going to surgery who have spinal stenosis, finding amyloid in that ligament, and then testing them for amyloidosis, with the idea that the amyloid in the spinal ligament may precede the development of systemic amyloidosis affecting the heart or the nerves by 5 or 10 years. That data is supported by this other really interesting study that was performed in Denmark, where they looked at not spinal stenosis surgery, but carpal tunnel surgery. Here they looked at patients who were undergoing carpal tunnel release surgery for carpal tunnel syndrome. And they found that when they tested those patients for amyloidosis later on, they found 12 new cases, and that the percentage of patients who had cardiac amyloidosis, who had carpal tunnel surgery, in this case, it was bilateral carpal tunnel surgery, years before, increased to about 20%, particularly if they were male. You can see here the men are blue and the women are red, and they were over the age of 70 years. So again, this suggests that looking at the carpal tunnel and looking at the spinal ligament might be a way to identify people before they have systemic evidence of amyloid disease, and that's the time when our treatments are most effective. Now, this slide illustrates the echocardiographic images, cardiac ultrasound of a patient with amyloidosis and a normal heart. And most echocardiographers would recognize amyloidosis at this point. The heart muscle is thick, the squeezing function is still normal, but we don't want to get to a point where a patient's heart has doubled in size. We want to identify people where they've got early disease, and that's the promise of exciting new nuclear imaging using something called PET, or positron emission tomography. So in PET imaging, there are a couple of different agents that have been tested. One of them that was recently reported called evuzametide, also known as ATO1, and the other name for it is the chemical name P5+14. This is an amyloid agent that was developed by Dr. Jonathan Wall at the University of Tennessee, and it binds to amyloid in the heart as well as amyloid in the body. And another agent that's already been developed and is actually FDA approved for amyloid imaging in the brain, called florbetapir, is another way in which amyloid can be identified in the heart. What this new imaging agent called evuzametide does is it might even identify patients, you can see here, who have evuzametide uptake. The heart is lighting up here when their SPECT, the PYP scan, is kind of like not particularly positive. It's weakly positive, maybe not. So this suggests that using this new agent called evuzametide, or ATO1, we might be able to identify cardiac amyloidosis even earlier than we could do even with our state-of-the-art SPECT-CT imaging with PYP or DPD, the current imaging standard. Now, turning our attention to treatment, again, Dr. Siddiqui already introduced this to you. In 2024, the only approved treatment right now is still tafamidis. We're excited about some new treatments we'll talk about if you have cardiomyopathy, whereas if you have ATTR cardiomyopathy with neuropathy, there are other treatments that I think you're all well aware of that Dr. Siddiqui covered. Now, let's talk about stabilizer therapy, and this is a slide you've already seen before. Acoramidis, also known as AG10, made by the company BridgeBio or Eidos Therapeutics, is a new orally available 800 milligram twice a day pill that patients take. And it mimics the action of a rare TTR variant called T119M that stabilizes TTR. So it binds to a TTR and stabilizes it in a different place than tafamidis. It achieved a very high stabilization of TTR in laboratory testing, and in a trial called ATTRibute-CM, a trial of 630 or so patients, they tested whether acoramidis would be better than placebo in patients with cardiac amyloidosis. And I'll tell you that acoramidis, like tafamidis, is very well tolerated by patients. There were no significant differences in the side effect profiles between patients who got acoramidis and patients who got placebo. And this is a curve showing the efficacy of acoramidis, which turned out to be quite positive. So the blue line here is the placebo curve, and this is survival, and the yellow line here is tafamidis, and this is 30 months of therapy. And acoramidis, and acoramidis resulted in an absolute improvement of 6.4% of mortality. That was statistically significant using something called a win ratio, and this gets a little bit confusing. Now, the win ratio is this concept of looking at a bunch of different endpoints and hierarchically arranging them based upon their importance. So they looked at death, they looked at hospitalization for heart failure, and they looked at change of something called NT-proBNP and difference in 6-minute walk distance. These are all established markers in cardiac amyloidosis. And acoramidis won pretty much across the board, leading to a very significant win ratio when you count the number of wins versus losses of 1.8. And here, basically, you look at patients who are on acoramidis versus patients who are on placebo, and you compare whether or not they died, whether or not they had heart failure, hospitalization, et cetera, and you compare each patient to each control. So the number of comparisons is very high, which increases the statistical power of the study. So on this basis, acoramidis is being considered by the FDA for approval for cardiac amyloidosis. So this will, if it does get approved, which the evidence based upon this study suggests it would be the second therapy approved for cardiac amyloidosis without a TTR variant. Now let's look at silencer therapy, and I've modified the slide slightly to include the most recent approved silencers as discussed by Dr. Siddiqui. So the drug patisiran, which is approved for hereditary amyloidosis of polyneuropathy, was tested in the trial called Apollo B that was published by my colleague Dr. Maurer in the New England Journal of Medicine last year. Apollo B looked at adding patisiran to placebo or a background of tafamidis in about a quarter of patients, and they looked at 12 months whether or not there was a change in proBNP, which you can see here, or a change in troponin. And what they found was that there was a significant improvement in not only biomarkers, troponin and BNP here and troponin here, but also 6-minute walk distance. And this is a study of about 200 or 300 or so patients, mean age of about 76 years. You can see here, and most of them were wild type, 80% were wild type, and about a quarter were on tafamidis, as you can see here. Now, the trial was statistically significant. It achieved its endpoints, but the magnitude of difference was relatively modest. Even so, the FDA advisory panel voted 9-3, saying that the benefits outweighed the risks and recommended approval, but the FDA declined to approve the medication and expand the label to include cardiac amyloidosis because they felt that the magnitude of improvement was too modest, and therefore Alnylam decided to not proceed with expanding the access of this medication. Now, Alnylam makes vutrisiran, which is being studied in the Helios B trial that Dr. Siddiqui mentioned, which is a relative of patisiran, and we are optimistic that trial will be positive and provide additional therapeutic options for our patients. But I'll point out that patisiran actually did make people better in secondary endpoint analysis, and these are again data from Dr. Maurer's study. Now the yellow lines are worse, and the kind of greenish lines are better. And you can see here that patients who are on placebo generally were trending worse, whereas the blue patients on patisiran were basically trending better. And these are echocardiographic measures that basically indicate heart size and heart function. So patients who are on patisiran trended better. They seem to get better, but this trial probably wasn't long enough to demonstrate whether or not that the improvement that they were seeing would become clinically significant enough to merit expansion of approval. So in any respect, patisiran is no longer being pursued for cardiac amyloidosis. Now, Dr. Siddiqui also mentioned to you about antibodies, and I just want to point out this fascinating study that was published by Dr. Mariana Fontana at the National Amyloidosis Center in London. And this basically kind of reinforces the antibody question. And this is a miraculous story of 3 patients who had spontaneous complete reversal of their amyloid cardiomyopathy. Now, the National Amyloidosis Center is one of the largest, if not the largest, volume amyloid center in the world, and they see a lot of patients. You can see here, only 3 patients in 1,600 that they evaluated had this effect. But what you can see here is that this is their DPD scan, went from a lot of uptake here, very clearly abnormal, to almost no uptake here, and that's validated here on this SPECT CT image. And the MRI also got better for these patients. So these patients had polyclonal antibodies that bound to amyloid and induced the body to remove the amyloid deposits. And this gives us hope that the monoclonal antibodies that Dr. Siddiqui mentioned, as well as the early clinical trial results, suggest that the body might be able to be induced to remove amyloid deposits. Finally, I want to take a minute or two to talk about non-amyloid treatments for heart failure. I think you're all familiar with the diuretics that we use, and we don't use medications like sacubitril valsartan, which is called Entresto. We use a lot of mineralocorticoid antagonists like spironolactone, and for advanced patients, we use advanced circulatory support or even consider heart transplant. But there's a new medication called an SGLT2 inhibitor, which stands for sodium glucose cotransporter 2. And this medication, there's 2 medications that are currently marketed called Jardiance or empagliflozin and Farxiga or dapagliflozin. And those names are pronounced slightly differently by different people. These were developed as diabetes medications that are designed to reduce the absorption of glucose in the urine and increase the excretion of glucose. And they do work that way in diabetes. But they have been shown to be tremendously helpful in patients with heart failure. They make people with heart failure symptoms feel better, reduce their hospitalizations, and improve survival. And it also slows the decline in kidney function. Now, how it works is subject to debate, and it probably works not necessarily through increasing glucose excretion in the urine and peeing out more liquid, but directly affecting the heart and kidney cells, and we can discuss some theories in the Q&A. So there isn't a general consensus exactly about how these medications work exclusively, but they are clearly beneficial in all different forms of heart failure, and we are now using them in ATTR cardiac amyloidosis. There are clinical trials that are underway right now, but generally these medications are very well tolerated by patients. And there are some cautions: patients who have urinary tract infections, patients who have advanced kidney disease, etc. We can discuss in the Q&A, but you will find that many patients with heart failure from cardiac amyloidosis are being put on these medications. And oftentimes you can reduce the dose of diuretic with these medications as well, and they work in tandem with the mineralocorticoid antagonists like spironolactone or eplerenone. So finally, I just want to point out that there's great interest in advocacy and partnerships. And the Amyloidosis Research Consortium has convened a partnership with the U.S. FDA called the Amyloidosis Forum, where investigators and academic specialists of amyloid and clinical specialists and patients and industry partners and federal regulators and also representation from research organizations like the NIH get together and talk about amyloidosis, key issues of amyloidosis in terms of clinical trials and getting new drugs approved for patients. And there have been a number of important meetings, including one about AL amyloidosis and a couple about ATTR amyloidosis you can see held in November in 2022 and 2023. And I think you're going to see a number of publications in the medical literature and also coverage in the lay press about this partnership, which is very powerful and brings all different voices together. It's really important that the people who are designing trials and supervising the approval of drugs understand the voices of patients and the experiences that patients have when confronting amyloidosis. And this is a tremendously important collaboration that I'm pleased to be part of. So with that, I'd like to thank you for your attention, and I really hope this was a informative presentation for you and you learned something, and I'm looking forward to answering your questions in the Q&A.
Thank you. We are now going to transition to our Q&A portion of the program. You still have time to submit your questions in the Q&A box to the right of the slides on your screen. And I'll turn it over to Dr. Ruberg to go ahead and read the questions aloud and then go ahead and answer them. Thank you.
Okay, great. Can everybody hear me okay?
Yes, your audio was great.
Okay, wonderful. Well, it's just a pleasure for me to be here, and I know that Dr. Siddiqui feels the same way. And maybe I'll let him just say a quick hello to test his microphone as well.
Hi, everybody. This is Omar Siddiqui. Can you hear me?
Yes, we can hear you. Great.
Oh, perfect. Thank you.
Thanks, Omar. Okay, let's get rolling with the questions. We have about 50 minutes, I think, and I'm just going to read these in the order in which they are kind of popping up on my screen, which I think is starting with the very first question. And the first question from James Wright is about ATTR wild-type polyneuropathy and whether or not Alnylam intends to ask for approval for ATTR wild-type polyneuropathy. And maybe Omar, I think he was referring to one of the questions from your presentation. So would you like to answer that question?
Yes, thank you. Thank you for the question. I think that this is in reference to patisiran and efficacy in ATTR, hereditary ATTR polyneuropathy, and how it has not been approved for ATTR wild-type cardiomyopathy. And I guess the question is, would it be applicable or would it be approved for people with ATTR wild-type polyneuropathy or peripheral neuropathy? If I'm understanding that question, I think it's an interesting one. I think the spectrum of ATTR wild-type disease is still being discovered, and I think that the fact that there is a peripheral neuropathy with ATTR wild-type disease was contested for some time. It was thought that this was a disease that purely involved the heart. I think increasingly we're realizing that patients also have a peripheral neuropathy. Now, I think that it is not known if that peripheral neuropathy exists in isolation without cardiomyopathy. I cannot recall seeing a patient with just transthyretin peripheral neuropathy wild type in the absence of cardiac involvement. Certainly, we see patients with soft tissue involvement. So I guess my point is that most patients who have the peripheral neuropathy also will have cardiac involvement. As such, I think Alnylam is not interested in pursuing patisiran, at least for that indication. I think that they are interested in pursuing vutrisiran for the cardiomyopathy indication, but I think that there isn't really this thought that the peripheral neuropathy is sort of a separate entity in ATTR wild-type disease, and so I have not heard of the development of drugs for targeting just the peripheral neuropathy in wild-type disease. Dr. Ruberg, would you like to add anything to that?
No, that was really very well and clearly explained, Dr. Siddiqui. I don't think I would add anything at all. So great answer. Okay, I will move on. The next couple I think I will take. The next question from James Blinn is, can Vyndamax cause your TSH level to become high so that you need to take levothyroxine? This is a really thoughtful question because the way Vyndamax or tafamidis works is it binds to TTR, and theoretically, TTR, transthyretin, which is a thyroid hormone transport protein, and theoretically, it could interact with the body's capacity to regulate thyroid hormone. Well, it turns out that TTR actually isn't a very important transporter of thyroid hormone in humans. There's another protein that does that, and that is called thyroid binding globulin. And so changes in TTR concentration, even with silencing medications, don't really affect the thyroid function significantly. So if you became hypothyroid and needed more levothyroxine or less levothyroxine if you were already hypothyroid, the change was not related to the administration of tafamidis or Vyndamax as far as the data show at this point. So I think I can answer that one as a solid no. The next question I will also take from Diane Bugoski. I'm sorry if I mispronounced your last name. And this is a question about how imaging could address a discrepancy in identifying female patients with ATTR amyloidosis. And this is another great question. So as the audience knows, most of the patients who have been identified with ATTR amyloidosis, either mostly wild type, but also hereditary, have been men. And you ask the question, why is that? What is it about being male, and particularly an older male, that leads to the development, or at least the recognition, of ATTR wild type amyloidosis? And we don't know the answer to that question, to be completely honest, and that's an area of active investigation in my lab group as well as others. But I can tell you that part of it is just we're not looking. We're not looking well enough. And your question, Diane, is exactly right. When we start actively looking for people with more sensitive techniques, like nuclear imaging with PYP imaging or DPD imaging that I showed you, or the newer agents like evazametide or florbetapir that are these PET imaging tracers, we potentially could identify more women. And to that point, my group and I will be presenting some data at the International Society for Amyloidosis that actually prove that point, that without getting into the details and kind of disclosing the results before we present them, our data do suggest that when you start actively looking with sensitive imaging, and we just used PYP imaging, we didn't even use the PET imaging, we identify more women with ATTR amyloidosis. The next question is pretty quick. I'm going to kick this one over to Dr. Siddiqui. I think the answer is probably no, and I'll give him the one after that too. And that's from Marlon Orellana, excuse me. And do you know of any clinical trials for gelsolin amyloidosis?
Yeah, that's a really interesting question. Gelsolin amyloidosis is another form of amyloidosis. So as you guys all know, amyloidosis is not one disease, right? It's a family of diseases, and gelsolin is a very rare kind of amyloidosis that's associated a lot of times with eye problems and CNS problems, and can have a progressive course. So to my knowledge, there are no specific gelsolin trials. There was an interest in developing a pan-amyloid antibody, by the London group at the National Amyloidosis Center, by others, by Dr. Wall, for example, that would target amyloid fibrils from any precursor, including gelsolin, including, fibrinogen, et cetera. So gelsolin would play a role there, but to my knowledge, there aren't targeted gelsolin trials. And I think, Dr. Ruberg, you would agree.
I would agree, and I also agree with your point that a pan-amyloid antibody that has been attempted to be developed would work to remove any amyloid deposits, but as of yet, such an antibody has not been proven to be effective. So, okay, let's move on now. This next question is for you, Dr. Siddiqui, by Larry Harnett. And the question is about tafamidis. If drugs like tafamidis slow the process of amyloid formation, why are they only approved for those who already have cardiac involvement? In other words, wouldn't it be better to use these drugs to slow or even prevent amyloid fibrils from ever even reaching the heart? What a great question.
Yeah, that's a really, really good question. And it's a concept that we discuss almost every week at our weekly conference, right? Like, how do we anticipate if somebody is going to develop cardiac disease, and then how do we prevent it? And I think a lot of the newer trials are actually going to focus on that too at some point. There are two answers to your question. One is practical and one is philosophical. So the practical answer is that the trial, the seminal clinical trial, the ATTR-ACT or the TRACK trial published in the New England Journal of Medicine, that trial recruited patients with cardiac disease, with confirmed cardiac amyloidosis. And so the efficacy, the effectiveness of tafamidis has only been proven in that population, the population that was studied. And the reason the trial was designed that way is because to show that tafamidis worked, we needed to accrue a certain number of events, heart failure events, etc., heart clinical endpoints. And it's going to be difficult to accrue those heart clinical endpoints if you don't have cardiac disease. And so for practical reasons, the TRACK trial, Tribute, other trials, certainly the antibody trials and the CRISPR trial, they all are including patients or are recruiting patients with relatively advanced disease so as to garner enough clinical events to potentially show a difference. So the practical answer is we are using the drug in the population that it was studied. It was simply not studied in patients who don't have cardiac involvement for the prevention of development of cardiac disease. It just wasn't studied there. I think so that's the practical answer. The philosophical answer is also that we don't know who's going to develop cardiac disease. We follow patients at our amyloidosis center who have been found to have transthyretin amyloidosis in their carpal tunnel, for example, and we're following them longitudinally, but they don't have evidence of cardiac disease. And we don't know which patient is going to ultimately develop cardiac disease, if they all will, or if some people just simply don't develop cardiac disease. Anecdotally, I have some patients I see who I followed for several years who have soft tissue involvement with transthyretin amyloidosis, but no evidence of heart disease. So I think that's the other question, is that, we simply don't have a good way of knowing, who to give the drug to. We know that the drug doesn't necessarily help with just soft tissue amyloidosis, although that hasn't really been studied, but that's sort of our anecdotal experience. And so that's why right now the drug is FDA approved for patients with ATTR cardiac amyloidosis, both wild type and hereditary, and those are the patients we use the drug in. Rick, Dr. Ruberg, do you have anything to add to that?
I do. That's a great answer, and as usual, I completely agree with you. I will add that one thing. So Dr. Siddiqui mentioned that we don't know who really is at risk for ATTR amyloidosis, with the exception of people who hold a variant. If you have a pathological variant, right, then we know you're at risk for ATTR amyloidosis, but absolutely true for wild type. I mean, as I said, being an older man, which there are millions of them in the United States, is not a risk factor that's going to allow us to treat people. We just don't really know. But if you have a variant, then you're at increased risk. Now, we don't know the concordance, as I said in my presentation. Just because you have a variant doesn't mean you're going to develop cardiac amyloidosis. And you have to have a variant associated with cardiac amyloidosis, like V142I or T80A. So to understand that better, there will be a clinical trial that will be enrolling, and it's sponsored by the company BridgeBio that makes the drug acoramidis. That trial will be called ACT Early, and it will be a long, many years trial where people who have a pathological risk variant, so a risk that we know, they inherited a TTR variant that increases the likelihood of them having cardiac amyloidosis someday, those people will be randomized to taking the drug acoramidis versus not taking the drug, placebo, in a 50-50, 1-to-1 randomization. And so there are a lot of rules about who's going to be in the trial, and there are specific ways in which the trial the people who are taking the drug are identified as having cardiac amyloidosis. But the concept basically is that it's exactly what, Larry, you're suggesting. If we know you're at risk, and if we give you a drug, in this case acoramidis instead of tafamidis probably would work the same way, then you would potentially forestall the development of cardiac amyloidosis. We will not know that answer for many, many years, but we're obviously it's a really active area of investigation and a very thoughtful question. These are all great questions, I would add. The next question I think I can just quickly answer from Frank Caragiglio. And again, I'm so sorry about getting people's names wrong. And the print's kind of small on my computer. The question is Vyndamax proving effective? And the answer is yes. Many secondary analyses post-marketing have demonstrated that the drug is consistently improving survival and reducing heart failure hospitalization and improving quality of life with patients with cardiac amyloidosis who, like Dr. Siddiqui said, meet the inclusion criteria for the trial that demonstrated its efficacy. What does that mean? That means if you've got cardiac amyloid and you look like a patient who was in the clinical trial that proved the drug worked, then you're likely get better with this. However, if you're somebody with really, really advanced amyloidosis, unfortunately, then the drug isn't probably going to be as effective. So, but the drug is definitely proving to be effective. Dr. Siddiqui, I'll move this next question to you, and it's from Professor Joel Buxbaum. Hello, Joel. Thank you for joining us from San Diego. So Dr. Buxbaum asks, how do you choose the first drug to be used in any patient with ATTR cardiomyopathy? Is there differential responsiveness to the different agents in an individual patient? Another great, insightful question.
Yeah. Hello, Dr. Buxbaum. Thank you for the question. I think currently in April 2024, the answer is relatively easy because we only have one FDA-approved drug, which is tafamidis. And so all patients who have the disease are offered, the standard of care tafamidis. I think in the future, and hopefully in the near future, when there are other agents that are approved, particularly gene silencing therapies, and then down the road, perhaps CRISPR-based therapies or antibody-based therapies, I think that that's going to be a real question and a real therapeutic challenge. And I think it will invite some granularity in terms of how we think about these patients and what stage of the disease that they're at. I can envision a circumstance where somebody has early disease, mildly increased LV wall thickness, stage 1 disease by biomarkers, and maybe they preferentially get treated earlier on with gene silencing or with CRISPR if that's proven to be effective. So I can definitely see that there's going to be differential responsiveness, like you said, not only to different agents in individual patients, but also to people at different stages of the disease. And I think that we simply don't have the data for that. And I think studies like ACT Early will help kind of prove the efficacy of some therapies in preventing disease, for example. I do think that we will need more, like I said, more granularity in how we choose these agents. I think we just don't have the data. I think right now we use tafamidis in everybody because that's sort of the FDA approved therapy.
Right. He follows up with actually a corollary to that question, which is exactly what you're getting at, is when and if, but when likely acoramidis is approved, when would you take your patients who are presently on tafamidis and switch them to acoramidis, or would you do that? And that's a tough question to answer.
Yeah, I think the easy answer is, and that's going to be a lot of my answers to these kinds of questions, is we don't know. I think that there is in vitro evidence that acoramidis may bind to TTR sort of more robustly and may drive down prealbumin levels more, and certainly BridgeBio would promote that idea. But then Pfizer may counter with the study with essentially the design of ATTRibute versus ATTR-ACT, and how ATTR-ACT actually showed a mortality benefit where there was a composite benefit in ATTRibute, but the actual mortality benefit wasn't totally clear in the paper. So I think it's hard to know is the answer. Is acoramidis any better than tafamidis? We think that the mechanism of action is similar, and we think that whatever benefit is being accrued by TTR stabilization should be seen by both of those agents. Why should one use acoramidis? I think this is a question that BridgeBio is probably asking themselves, and I think that this is probably it'll come down to cost, right? I think tafamidis, when it first started, was prohibitively expensive, continues to be so, and I think that access to care is going to be an issue. And I think that acoramidis and BridgeBio has a real opportunity here to help us drive down the cost of these therapies and to allow patients access to them. So I think cost is going to be a big question here. I think efficacy-wise, I don't think any drug manufacturer is going to be interested in a head-to-head comparison. I think once we accrue enough experience with both drugs, we can probably look at retrospective studies of acoramidis versus tafamidis, but I doubt there will ever be a head-to-head randomized comparison, which is what you really need to answer your question.
Right, and I would add, just to follow up on that point, I think that a lot of these decisions may be made by your insurance company. They will have one or the other likely as their first TTR silencer, and that would be the drug that you would get. Now, however, though, there's another great question which segues perfectly from this question from Joseph Galea, and he says, I was diagnosed with ATTR wild type almost 4 years ago and have been on Vyndamax ever since. What is the best way to check if it is progressed? And that gets at the point of how do you know whether you've responded or not responded to a TTR disease-modifying therapy like tafamidis, which would then be a reason potentially to switch if a drug is not working, like we do with any other. Like if you're treating high blood pressure, you put somebody on a high blood pressure drug. It works for some people. It doesn't work for others. And you can figure out whether it's working because you measure someone's blood pressure. And if their blood pressure isn't lower, then you switch them to another medication. How do we do that in ATTR amyloidosis, Dr. Siddiqui?
Yeah, another excellent question. And again, this is a question that is the topic of much discussion at our weekly multidisciplinary amyloidosis meetings. How do you tell if somebody's responding? We listen to the patient. We'll ask you how you're doing, and we get a sense of subjective sense of your quality of life, your functional capacity. There are objective measures, certainly, so you can do metabolic stress testing, which we do sometimes. So that's one way we think about it, is how does the patient feel? Our hope is to at least arrest progression of their disease and maintain their quality of life. So if they feel that they can walk a lot less this year than they could last year, that is a sign of progression in our minds. We also have to think about other things. Are they developing atrial fibrillation? Are they developing worsening heart failure symptoms? And so symptomatic assessment of disease progression is one way that we do it. Another way that we do it, and those of you who go to amyloidosis centers or even cardiologists in general or physicians will check labs once a year, and we check a lot of blood. And one thing that we're checking for is cardiac biomarkers that Dr. Ruberg, I think, briefly mentioned, but talking about things like troponin and BNP. These are markers that leak from the heart and are a sign of disease, potentially a sign of disease progression if there's an increase in these markers. That obviously can also be complicated by kidney function, by the presence of atrial fibrillation, by volume overload, things like that. But the second bucket of things that we use are cardiac biomarkers. Then the third bucket of things that we use are basically imaging modalities, and particularly echocardiography. So we check an echo every year in our patients, and we look for progression of left ventricular wall thickness. We look for global longitudinal strain, although the decrement in that is it's a little controversial. How much does it prognosticate? But we look at echo parameters of disease, essentially. So basically, we look at three major buckets. We look at symptoms, we look at biomarkers, we look at echo or imaging features of disease progression. And then honestly, it's a little bit of and that's why we have these multidisciplinary meetings, because it's a little bit of like the art of medicine, figuring out if somebody's truly progressing. There are one other thing I'll say. Sorry, Dr. Ruberg. One other thing I'll say is that there is some evidence with advanced imaging modalities like cardiac MRI and particularly nuclear scintigraphy, so pyrophosphate scan, for example, where there may be a change in uptake of those radiotracers in response to certain therapies. And I think there's a lot of interest in probing that further and what that means. Dr. Ruberg.
No, I was going to say that's a wonderful survey and overview. I think on the point of advanced imaging, I'd say I think probably the evidence is better. Probably that MRI, extracellular volume, which is a measurement that we do by MRI, might be more reliable than changes in uptake, but we don't really know that for sure at this time. And so basically what Dr. Siddiqui explained to you is that there are many different ways in which you can, you as a patient can be assessed to figure out whether your amyloidosis is getting worse or better or staying the same. And there's general agreement about how one assesses a patient, but it's a combination of all these things together. And the decision that whether someone is worsening really kind of involves integration of all those different data inputs, and best is through kind of a multidisciplinary team before you make the decision potentially to move someone from one therapy to another, which will become an option. I mean, right now we have still one treatment, but we will likely have many more treatments in a short few years, honestly, and then it'll be really important to figure out whether or not someone is getting better, getting worse, or staying the same. We're doing really well. We have about half an hour left for questions. Thank you all for hanging on. There's a question from Kent Wong, and that is about how the antibody that reduced and reversed amyloid in those 3 patients that I showed you is acquired. Well, unfortunately, I got some bad news. It's not acquired. Those were not manufactured antibodies by a company. Those were spontaneous antibodies that those patients actually developed on their own, that we believe, that caused the amyloid to resolve. And this is why it was this is why it got published, arguably the most influential medical journal in the world, because it's such a rarity. But, it happened. It appears to have happened. These patients convincingly had, change in all of the measurements that we just talked about a second ago, Dr. Siddiqui mentioned, where the amyloid was clearly in the heart and then it went away and they figured it out. And then the doctors at the National Amyloidosis Center figured out that it was related to antibodies that the patients developed themselves. Obviously, that is something that struck a lot of interest, and there's investigation about whether that process could be identified, what triggered the development of those antibodies, and how were those antibodies made by those patients, and could potentially that could be mimicked in another patient. You can imagine that if we understood how that happened, we could induce other patients to develop the same antibodies and have the same outcome. But that's kind of more aspirational, and we'll see if that actually could ever happen. But it's definitely kind of exciting, and I think most people probably would have thought something like that could happen, but the body amazes us. Moving on here. There's a question from Stanton Abel about detecting amyloid in eye muscles. I can say that with MRI, you can see eye muscles possibly you could see some thickening. I would expect. I'm not a neuroradiologist because they're the specialists who look at eye muscles by imaging. But none of the imaging tracers that we have, except maybe the new one, evazametide, because it theoretically can see amyloid anywhere in the body, might have enough resolution to see eye muscle amyloid. But I think the answer for that is probably nothing specific. Okay. Here's a good one for you, Dr. Siddiqui. It was something we talk about a lot, and this is from James Wright. I was diagnosed with ATTR wild type from a spinal ligament from the fourth of my 7 spinal surgeries. I'm sorry, Mr. Wright, you've had so many back surgeries. But they found amyloid there, and now the PYP scan shows a little uptake in my heart. But my polyneuropathy has gotten progressively worse, and there is no treatment for my particular case, I'm assuming because he has wild type, and he has polyneuropathy, and not enough amyloid uptake in his heart by PYP imaging to prompt tafamidis. That's what I'm inferring from this question. So Dr. Siddiqui, talk to us about amyloid identified in the spinal ligament and what that means about subsequent cardiac amyloidosis.
I think that and Dr. Ruberg really is the expert on this, and I'll defer to him after I take a shot at the answer. But thanks for the question. So I think that this is the subject of the trials that Dr. Ruberg has mentioned, right? His most recent sort of R01 trial R01 funded sort of trial looking at patients who have transthyretin protein in their spinal ligament and following them longitudinally. We have definitely done that in our clinic, and not everybody develops heart disease. Now, some people may develop some heart disease, and it sounds like, Mr. Wright, you may have a little bit of uptake in the heart, but not enough, perhaps, to warrant treatment. But your peripheral neuropathy has been progressively worsening. A couple of approaches here that we have taken in the past. We do know that the Portuguese experience with tafamidis in hereditary peripheral neuropathy was that it may stabilize disease slightly, and it wasn't, the FDA did not think that it was compelling to approve the drug for peripheral neuropathy in patients with hereditary disease. Obviously, patients with wild-type disease are different, and we don't know much about their peripheral neuropathy and how it progresses and what it responds to. One tack that we have taken in the past, if patients have some evidence of cardiac involvement and their insurance companies allow them to be on tafamidis, then we have tried tafamidis in those cases. But understanding that the efficacy for a peripheral neuropathy is probably limited, and that's been our anecdotal experience as well. The other thing we've done in the past is using another drug that we haven't really discussed at all here, which is diflunisal. Diflunisal is a non-steroidal anti-inflammatory agent. It was actually one of the original transthyretin stabilizers, and it is something that our group and others have shown some efficacy in cardiac disease, and actually Dr. Burke of the Amyloidosis Center ran something called the diflunisal trial in patients with hereditary disease and peripheral neuropathy and showed a benefit in those patients. So in patients who have transthyretin amyloid in their spinal ligament without evidence of cardiac disease but with a peripheral neuropathy, there are times that we have tried diflunisal as a transthyretin stabilizer. Now, diflunisal is a non-steroidal anti-inflammatory. It's kind of like taking ibuprofen every day. So you need to watch out for things like acid reflux, which is something that patients will get commonly, and sometimes we prescribe a PPI, a proton pump inhibitor, or an acid-suppressing medicine routinely. Patients are also at risk for developing kidney dysfunction because they're taking an NSAID routinely. So diflunisal is not without its side effects, and it needs to be monitored very carefully. But those are two tacks that we have taken in your situation with spinal disease, progressive peripheral neuropathy with no significant cardiac uptake. Either trying tafamidis if that's accessible, but again, understanding it's not very effective probably in that case, or trying diflunisal. The benefit of diflunisal that I have noticed in my patients is that because it's a non-steroidal anti-inflammatory, it does prevent, or it does help with the pain associated with spinal stenosis and soft tissue involvement. So it does function, it does have a dual role as a TTR stabilizer and as an NSAID. So that sometimes can be beneficial in patients such as you, Mr. Wright. Dr. Ruberg, anything you would add to that?
No, great answer. I just one slight correction in that research grant that you alluded to is actually Dr. Maurer's grant, and I'm a co-investigator.
Okay.
I want to give credit to my colleague. It was his idea, and I'm just kind of going along for the ride. But we are trying to understand whether or not amyloid in the spinal ligament precedes the development of cardiac amyloidosis by as many as 5 to 10 years. Now, I'll add that that's mirrored in the literature that's developed around the carpal tunnel. Many of you probably know about carpal tunnel syndrome, and particularly bilateral carpal tunnel syndrome being a marker for amyloidosis. And so I think that that's another important area that I have spoken frequently about, where basically that could also be seen as a place where you might see amyloid in the soft tissue there, and that could precede the development of amyloid in the heart. I happen to also know that at the International Society for Amyloidosis in a month, my group, our group actually, is going to be presenting some data on that. And a lot of the work on this has been done at Cleveland Clinic by Maz and Hannah, showing that how many patients who have carpal tunnel syndrome and have amyloid in the carpal tunnel ultimately progress to amyloid. It really their initial demonstration was about 10%. I think as you follow people longer, that number increases. And we know that if you look at patients who had carpal tunnel syndrome surgery 10 years prior, it's a study out of Denmark, that as people get older, particularly if you're male, as we discussed before, the likelihood of developing cardiac amyloidosis goes up manyfold. So I think if you have amyloid in the spinal ligament or the carpal tunnel and you don't have any evidence of cardiac involvement, you should be followed on a regular basis. You may never develop cardiac amyloidosis. We don't know if you will or you won't, but it merits being followed. So one quick question I will answer, and then I'll turn it back to Dr. Siddiqui. This is from Marianne Bazile. It's asked for clarification on what's happening with patisiran. The question is, will Alnylam pursue patisiran for wild-type cardiomyopathy without neuropathy? And the answer, I believe, is no. Alnylam will not pursue patisiran, but they have another drug called vutrisiran, which I believe Dr. Siddiqui mentioned in his presentation, that's being studied in a trial called Helios-B. Helios-A was the trial of that drug in amyloid polyneuropathy, hereditary, which led to its approval by FDA. So Helios-B is studying whether or not that drug vutrisiran, made by Alnylam, injected not every 3 weeks, but I think on a 3 to 4 month basis. Always never remember the interval, but that drug will hopefully be effective in ATTR cardiomyopathy through the Helios-B study, and that's the drug they will be pursuing, based upon what I know from the lay press. I don't have any inside knowledge there. Okay, Omar, Dr. Siddiqui, this is a question from James Blinn. How much metoprolol is reasonable to take with ATTR cardiomyopathy, wild-type cardiomyopathy in this particular case? He's heard that there's some issues with metoprolol. So what can you tell us about that?
Absolutely. So again, really sort of a very, very practical question, one that we grapple with all the time. Taking a step back, therapies that are commonly used in patients with heart disease in general, like metoprolol, which is a beta blocker, calcium channel blockers, digoxin, etc., we know are not well tolerated in patients with cardiac amyloidosis. So in the case of beta blockers such as metoprolol, these drugs are used to slow down the heart rate in patients who have atrial fibrillation. They're also used to prevent adverse remodeling of the heart in patients who have a weak heart. We also use them sometimes in patients with coronary disease, for example. The problem with cardiomyopathy from transthyretin, ATTR cardiomyopathy, is that patients are very sensitive to changes in their heart rate, and beta blockers can basically precipitate symptoms of heart failure. Beta blockers can also cause patients to become very fatigued, and that's something I see commonly, is that patients will be started on metoprolol and they'll be extremely fatigued, and will stop the drug and they'll feel better. There isn't actually a set dosage. There is not a threshold effect that I'm aware of, and it tends to vary from patient to patient. And so one thing we do, if we are pushed into, if we absolutely have to start metoprolol because somebody's heart rate is really high in atrial fibrillation, for example, then what I'll do is I'll start at a very low dose. So I'll start metoprolol succinate, the long-acting form, 12.5 milligrams daily, which is kind of half of the lower dose, and see if they tolerate it. I certainly don't try to push much beyond 25 milligrams because patients will develop significant fatigue and heart failure symptoms. But, your question is a good one. There isn't really a set cutoff. I think it really depends on what patients are tolerating. There are some patients who who are on metoprolol, maybe it preceded their diagnosis, and they tend to tolerate the drug and we keep them on it. So we don't have a set dose beyond which we don't, beyond which we don't use the drug or anything like that.
I agree, and I would add a couple of additional points. One, that there's evidence that deprescribing metoprolol dose or beta blocker dose can make people feel better and live longer. So if you're on a high-dose beta blocker, one of the first things that Dr. Siddiqui and I do in clinic is bring that beta blocker down, and invariably people feel better. The use of beta blockers in ATTR cardiomyopathy is primarily for rhythm control, when people have atrial fibrillation, or if they have ventricular tachycardia, or other extra beats or something like that. In other forms of heart failure, we use them as a routine. They're considered standard of care, and every patient with say heart failure with reduced heart function should be on a beta blocker. But in amyloid, we observe that that's not the case. Last thing I'll say also is that there is some evidence from the National Amyloidosis Center in London that beta blocker at low dose may be beneficial in patients with lower heart function. But these data are, so I don't think we're at a point where everybody with amyloid and an LVEF, or it's a heart function below a certain level, should be started on a beta blocker, but it's an area of kind of active investigation. So I'm not as quick to take it away completely when patients are tolerating it, especially if they have low heart function. And what do I mean by tolerating it? I mean that they don't have low blood pressure, they're not fatigued, and their heart failure symptoms are easily controllable. So okay, so maybe I'll get this next question to you, Omar, as well. So this is basically a question from Andrea Burke. We have about 15 minutes left. And she asked the question about basically how to, I'm assuming I should say they, but they asked the question about how to follow patients who have inherited risk variants but don't yet have clinically evident amyloidosis. And they write that father and uncle unfortunately passed away from amyloid cardiomyopathy and had rapidly declining health really for the last 10, 15 years of their life, so maybe starting in their 60s, or maybe even their late 50s, and they have been tested, and about 50-50 of the family has the gene and doesn't. And the question is, how do you suggest we get followed? What are the ways in which we follow patients when we know that there is a family history of it's called penetrant disease? So people have a gene, and the gene has led to amyloidosis at a particular age. So if that patient walked into your clinic, Andrea Burke walked into your clinic, what would you tell them?
Yeah, I think it depends on a couple of, so it depends on the mutation. We know that some mutations likely, and we actually don't know this definitively, but we know that some mutations have more penetrance, meaning that if you carry the mutation, you're more likely to get the disease versus others. But for no mutation, do we know if they are 100% penetrant, meaning we don't know if everybody who carries the disease, the mutation is going to get the disease. Furthermore, there seems to be some gender or sex disparities as well, where females may get cardiac disease later on than males who carry the allele. So there are probably sex-related differences as well. The way we do it at our center is we perform a baseline assessment with labs, cardiac biomarkers, troponin, BNP, echocardiogram, and a pyrophosphate scan or nuclear scintigraphy to look for cardiac uptake. If there is no evidence of clinical cardiac disease, then we follow those patients longitudinally every few years. And it is very helpful to know when, if there were patients in their family, if there are family members who develop the disease, it's helpful to know when they develop the disease so that we can kind of intensify our surveillance closer to that age. So, for example, if you had if your father developed, cardiac disease at the age of 60, then I'm going to start paying more attention or be a little bit more deliberate with my screening around the age of 50 or 55 just to make sure we catch it early. But if somebody comes in at the age of 30 and their family member had the disease in their 60s or 70s, I can probably space out surveillance in that case. But surveillance basically consists of longitudinal sort of follow-up with echocardiogram, blood tests for cardiac biomarkers, and advanced imaging, usually nuclear scintigraphy, to see if they're going to develop disease down the road. We don't have a great strategy for doing this, and we also don't know when to repeat nuclear scintigraphy, like pyrophosphate scan, for example. Most of us will repeat it in 5 years or so. But then when you approach the age at which your relative developed the disease, we may start doing surveillance kind of sooner at shorter time intervals. But that's kind of something we've come up with as a consensus strategy. Dr. Ruberg, do you have anything to add to that?
Yeah, I would completely agree. I think this is an area of a fair amount of variation in different centers. Dr. Siddiqui mentioned about pyrophosphate imaging in the United States or DPD imaging in Europe. Other centers use cardiac MRI, as their primary imaging agent, or they do both. And so the European Society of Cardiology, in their guidelines that were first authored by Pablo Garcia Pavia, did get into some of these recommendations in general terms regarding testing and intervals, but not absolute specifics about what one should do and when. And I think it's really kind of at the discretion of the specialty center. And in this particular patient's case, I mean, there is unfortunately a high likelihood of development of disease because of a father and an uncle who had it. I will say, just like Omar said, men develop ATTR amyloidosis typically earlier than women, and it is possible that it'll be, that's true in almost every variant that I know of, and it is possible that there won't be penetrant disease, but I think the risk is certainly higher, and so regular assessments in the way that Dr. Siddiqui mentioned would be appropriate. And at the first signs of disease, evidence, whether it's evidence of amyloid in a peripheral biopsy like a fat aspirate, or change in heart markers, or change in imaging, or sensitive imaging like even evuzametide or chlorbetapir, the PET imaging that I talked about, which is not clinically available yet, but hopefully will be in the future. Then you'd begin treatment. So it is a moving target, and this is why the study, I think, Act Early was conceived, and why I find it an interesting study, because the concept basically is that this is exactly the type of patient who would be included in such a study. So we have about 10 minutes left, a little bit less than that, and there are a few more questions I'd like to get to. I think I'll take this one first, and then I'll let Dr. Siddiqui comment, and this is on SGLT2 inhibitors. This is from Stanton Abel. So SGLT2 inhibitors have really kind of been a game changer in the past couple of years in heart failure. There haven't been many drugs that have been effective for congestive heart failure across the spectrum of heart failure that we see. Strong, like normal function, reduced function, all these different types. And this class of medications is really among the first, if not the first, to actually show efficacy. What do I mean by efficacy? I mean people live longer, people stay out of the hospital, people feel better. SGLT2 inhibitors also work to slow the development of kidney dysfunction in patients who have chronic kidney disease as well. How do they work? That's kind of an unanswered question and the subject of considerable debate. They were, as I mentioned in my presentation, they were developed to basically essentially make you pee out more glucose in your urine, and that would basically lower your glucose and make your diabetes control better. But it turns out they actually work through a mechanism that affects the heart and the kidneys in a different way. One actual hypothesis that's gaining steam recently is that it changes the way in which it works directly upon the cells of the heart and the kidney, and changes the way in which they are kind of like they respond to stress and kind of starvation mechanisms, I guess is the best way to describe it. So we really don't know. At least I don't know exactly how they work. But again, this is a subject of kind of considerable debate in the literature. But they work. They definitely work well. Now the side effects are, as I mentioned, there is a propensity to urinary tract infections in some individuals, and they can slightly worsen kidney function. But usually that worsening actually is not indicative of worsening function. It's just a measuring difference based upon the changes in the kidney blood flow that the drug causes. So those are kind of the principal side effects. So we're using them a lot in all heart failure, and we've begun using them in cardiomyopathy and amyloid cardiomyopathy. There still isn't really good data yet out there, but there will be very soon. I'm aware of some reports and studies that will be published that should demonstrate these drugs are effective in cardiac amyloidosis and doing what we think that they do. They make people feel better. Will people live longer? I'm actually not sure. In the context of like the drugs like tafamidis and acoramidis, disease-modifying therapies, I'm not sure they will necessarily make people live longer, but they certainly will make people feel better and hopefully stay out of the hospital, and that's obviously of great importance. So anything else you want to add to that, Omar?
No, I think you covered everything. I think that's good.
Okay. So moving on to, we have about 5 more minutes for a couple more questions. Okay, so what's known about the ramifications of TTR silencer approach versus stabilizers? In other words, how do you, Dr. Siddiqui, approach? How do you think about those two, and what will be the downsides potentially to those? The question is the ramifications. So I think that's a side effect question from Frank Caraglio.
Caraglio, maybe, yeah. Right. So the ramifications of using TTR silencer approach as opposed to addressing misfoldings. I think that TTR stabilization with tafamidis, we know that it does not prevent. So first of all, in terms of mechanism, right, it does not prevent the deposition of amyloid fibrils in the heart, at least, right? We know that people will progress. It will slow down the rate of progression, but people do progress, and that's been our clinical kind of experience as well. It provides a mortality benefit, it provides improvement, but down the road people do progress. So one of the things is that you're not. It's not sort of an irreversible sort of mechanism. People will still have the disease. Now the idea behind gene silencing is you're shutting down as my mentor and colleague Dr. Santorwala says, you're shutting down the amyloid factory. You're preventing production of the amyloid from the get-go, amyloid precursor protein from the liver in this case, by using gene silencing. So the idea is that you're going to just prevent any further deposition. But again, those patients who already have disease, amyloid fibrils in their heart may still progress. In terms of side effects, we think that tafamidis is very safe, and that's sort of our experience with TTR stabilization, is that, we have not noticed any issues with thyroid hormone metabolism or transport. We have not noticed any issues with vitamin A deficiency and things like that. Tafamidis has been exceedingly safe, without very many side effects. I had earlier mentioned the TTR stabilizer diflunisal and how that does have side effects because of its non-steroidal anti-inflammatory properties. The gene silencing treatments, these are drugs. So the drugs that are approved right now are patisiran and inotersen and epiontersen and vutrisiran. These are basically given by IV or subcutaneous injection. They act on the liver, they prevent production of the protein, and they are linked to side effects, including infusion reactions. And that's why those of you who are getting the drug know that, especially for patisiran and inotersen, you are pre-medicated with Benadryl and a lot of other, H2 blockers, things like that, Zantac, ranitidine, etc. The subcutaneous vutrisiran doesn't require pre-medications. So there are some kind of reactions to the infusion. Also, by suppressing production of transthyretin altogether, there is at least the theoretical concern for vitamin A deficiency, and that's something that we, counter by vitamin A supplementation. So that's one of the ramifications of TTR silencing. But yeah, so that's basically how we think about these two mechanisms of treatment.
Thank you very much. I agree with that summary. Thank you. That was perfect. I think we have we're almost at time. I think I probably have time for one quick question, and this is from Donald Benson. Does the efficacy of tafamidis and/or eplontersen help reduce symptoms of gastric discomfort, and does their efficacy compound with continued use? So I guess the question is, gastric discomfort can happen for many reasons, and in patients with ATTR polyneuropathy, if they have hereditary amyloidosis, oftentimes that results from problems with gastric emptying, which is a neuropathic problem, which could improve with eplontersen, which is approved for hereditary polyneuropathy. Now there are many different reasons why someone might have gastric discomfort. And so in wild-type cardiomyopathy, since neuropathy is not as commonly seen as a feature, in fact, a relatively uncommon feature, then it's probably not related to kind of a neuropathic process. So I guess it's the management of gastrointestinal symptoms with amyloidosis is a complicated one. And it was my colleagues and I recently covered it in a clinical document that we published from the American College of Cardiology, where we had an amyloid specialist gastroenterologist. John Clark from Stanford University was one of the lead authors of that section. And he wrote a lot about his experience of managing gastric discomfort. Sometimes it has to do with diet, of course, and people know that already. But it also has to do with kind of the bacterial microbiome of the gut. And there's certain medications that people can take to help improve gastric emptying. So if your doctor isn't aware of how to kind of manage a particular problem, you could refer them to this particular document, which provides, I think, good clinical guidance. So I think we're basically at time. These have been such great questions. It's been a lot of fun, I think, for Dr. Siddiqui and I to answer them. We've gotten through, I think, probably 90% of them. Again, I really appreciate the 78 of you who are still listening to us go on about amyloidosis, and hope that you found it informative and a good use of your time. Anything else you want to say, Omar? You have the last word. Or maybe our moderator does, but I will stop talking.
No, I just wanted to thank you all for being here, and the Amyloidosis Foundation and Prothena for sponsoring this and allowing us this platform to address this important disease and to address all of you. So thank you for your questions.
Thank you very much. This concludes today's program. This event will be available to view on the Amyloidosis Foundation website at www.amyloidosis.org within a few days. Thank you and have a great day.